Welcome everyone. Thank you for attending this webinar with Fullscript and Symphony Natural Health. My name is Kaylee, I'm with Fullscript, and we're very excited to have Dr. Mona Fahoum here today with us to discuss empirical evidence and case studies on natural alternative applications for fertility and reproductive health. Before we jump into things a bit, I'm just going to do a little housekeeping. So just a reminder that this is being recorded and will be sent to everyone who registered after the event, so you can watch it again whenever. We also have all of our webinars, past and upcoming, that live on our Fullscript website. So fullscript.com/webinars. You can find them all there, and this one will be up as soon as possible as well. And then throughout the webinar, there's a questions box on your dashboard, or like a section. If you have any questions, add them to that section, and we'll get to them at the Q&A period at the end of the presentation. So I'd like to thank Dr. Mona for being here today. Dr. Mona is a naturopathic doctor who specializes in women's health across all ages. From hormonal issues and digestive concerns to sports medicine and nutrition, she has a personalized approach, creating a unique plan for every patient. Dr. Mona has been in private practice at Meridian Medicine in Seattle for 15 years, and she's the Director of Clinical Services at Bastyr University, and most recently, the past president of the Washington Association of Naturopathic Physicians. Outside work, she is a mom, a wife, an avid snowboarder, a soccer player, and a CrossFitter. So with that being said, I'm going to pass it over to Dr. Mona and get started. I'm going to disappear for a bit, but I will be back for the Q&A section. All right,
great, thanks. Thanks, Kaylee. Thanks for setting us all up today and getting us all oriented to what we need to do. I need to show my screen and put it on the actual slideshow. There we go. Thanks everyone for coming in and taking some time today to learn a little bit more about feminescence in particular, and just fertility in general, and how we can approach this in a more natural way, and hopefully keep our patients out of the reproductive clinics needing IVF and all those types of things. So with that, we'll just go ahead and jump on in. We're going to talk about a couple of different items today. We're going to do case studies primarily, but we'll also talk about a little bit of preconception. I think the psycho-emotional components are really important to consider. We'll talk about men's health, women's health, and we'll just touch on briefly breastfeeding, in particular with the feminescence products. So preconception, I love this quote. Jan Roberts is one of our medical team members. She is a pharmacist from Australia, and she has written books on conception, preconception, all of those wonderful things, breastfeeding. And a quote from her here is, with infertility rates in the Western world increasing sharply in recent years, the primary focus for most parents is to simply conceive. Unfortunately, mirroring the rise in infertility, there's increasing rates of miscarriage, premature birth, birth defects, low birth weight, learning disabilities, and a multitude of other health issues. I think in our professions, I'm imagining many of us here today are in the natural health or allied health fields. We already understand this inherently with cleaning house and doing detox and preparing our bodies for something like conception and fertility. But these are just some basic stats on what we see out there. 1 in 6 couples is infertile. That's about 11% of women, 9% of men. I found it interesting in preparing for this that many infertile couples, it's really 40% is the male factor, which I think gets ignored sometimes, and emotionally and socially it gets put on females more often, but there really is a very strong male component there. And 30% of couples with fertility issues have unexplained fertility when you go through the standard evaluation. So that's also where, of course, our field and natural options are going to really help those folks who fall into the abyss of, we don't know what's wrong with you, or you're not getting pregnant. So here's some stats for you. You can read those. And next, here we go. So preconceptive planning. I love it when people will start about 6 months ahead of time and kind of think about what needs to happen. We know from the body burden study, a number of other studies, EWG, the Environmental Working Group, has some great papers on this and how many pollutants are in babies and placentas and newborns. if you want to do more reading on that, if you're not already aware of this, but chemical pollutants are showing up all over the place, and certainly in the mom, but then also then in the baby. And so I always think about doing some detox, gentle or otherwise, but actually I don't say otherwise, because I wouldn't be doing chelation or anything like that with someone who's thinking about getting pregnant, but certainly thinking about and going back to some of our basic tenets of medicine and how we eliminate toxins and prep our body. I always am talking to my patients about peeing, pooping, and sweating. Our 3 routes of elimination, they've got to be open, they've got to be moving. So before someone's thinking about getting pregnant, which many people do plan ahead now, of course the surprises happen, but if people are planning ahead, that's when we really have an opportunity to make sure that their gut health is good and they're having bowel movements and eliminating, their fiber intake is good. So they're grabbing things up and pulling them out, which is going to help hormone balance. We all know that, but it's also just going to help cleaning house in general. You may decide to think about a little bit of pH Quintessence, our alfalfa product, which is a very good, very gentle detoxifier. And of course, there's a number of good, detox or cleanse protein powders by companies and all of those other pieces that you know how to use, I'm sure. So next, beyond the preconception, I always want to just address this. I know we probably know a lot of this stuff and patients forget about it. So I just wanted to call our attention to it today so that we can really bring it up with our patients if they're not sure or they're stressed out about fertility. I often am telling my patients the #1 killer of fertility is the stress around it and thinking about it all the time, because it can be all consuming. And there's good reason for that, but we also have to try to keep it in context, try to encourage people. I'm always telling them to practice, practice. You just want to have a lot of fun with practice, have a lot of sex and keep it fun and try new things and make sure you're having date night still, because that's so important with lowering the adrenaline, lowering the cortisol, keeping things under good care and good balance, because stress is not conducive to a healthy body to prime itself for fertility. The other thing is, making sure and checking in with couples and making sure that they're on the same page. Do both partners want to have a baby? If you've been seeing patients for as long as I have, and I know my bio's at 15, but I'm actually in year 17 now, because people are having, one person of the couple is there to want to talk about having a baby, I've learned through experience that doesn't always mean the partner's on that same page. So do you need to talk about some marriage counseling? Fertility and everything else is going to work much better when everyone is on the same page, and any communication issues or fears from family of origin issues that a partner may be carrying in about not being a good parent, all of those things need to be a piece of our treatment plan. Managing anxiety and depression, making sure people are sleeping well. Especially for him, I find that sex can sometimes have become a chore because she's like, I'm ovulating, let's go, we got to do this right now. So just being aware of all of those pieces and the self-esteem issues that then can also result from feeling inadequate and that you can't perform something that you should be able to. Today, I'm focusing on more of the heterosexual couple, although much of this is around hormone balancing, and ovulation is obviously going to apply to other relationship types. But I just wanted to draw attention to that and remind you that there's actually ACOG has a committee opinion paper number 749. I wrote it down for this purpose, on how to better evaluate LGBTQ, intersex, asexual, and gender nonconforming individuals. So if that's a population you work with, then you're going to want to go out and get a little more education as well to what important issues face that population. Jumping into men's health. So like I mentioned before, male infertility is actually the cause of infertility in 40 to 50% of couples. I run into couples all the time. They've been trying to have sex or trying to have a baby, having sex, timing it all, things aren't happening. The gal is in there trying to figure out what's going on. Can we run hormone levels? Can we do all of this stuff? And the male partner isn't quite game to go and do that sperm analysis. And that's hugely important. So that's one of those communication pieces as a practitioner. And as a GP, I may not see the male as a patient, but we're absolutely, and I have a relationship with a lab here in Seattle Reproductive Medicine, who I can order the sperm analysis for, they'll run it, and then they'll give me the results. Even if the patient is not mine, there's a case to be made that we could justify that and go ahead and order that, even if he's a little hesitant about going and seeing a specialist himself. So that's one piece that I wanted to throw out there. And ideally, a semen analysis, they're going to have 2 to 5 days of abstinence before going to the lab and giving that sample. The other things for men is thinking about just general considerations. How much alcohol, beer, we know hops is a phytoestrogen, so we need to think about that. We know marijuana can be a phytoestrogen, especially here in Washington. It's legal, it's all over the place. You have to really screen to see if they're doing edibles every night or what's happening in their social life. And then, of course, any activities that could be affecting sperm production, biking, tight clothes are in. So addressing all of those other pieces. Another big issue is erectile dysfunction. And I often will turn to, and patients do better with these validated tools where they can kind of on their own answer some questions. And then that can then help you decide whether or not that conversation needs to happen about how well they can get, maintain, an erection, etc. So there's a couple of tools here for you that you can utilize, and just look up on Google, you'll be able to find the tool. One thing to remember is that men with erectile dysfunction, even without any history of cardiovascular disease, have a 45% increased risk of having a cardiovascular event within 5 years compared to those men who don't have erectile dysfunction. So we could be going a long way just with preventive medicine for this population. They may be complaining about infertility and erectile dysfunction, but there's a lot of other things that we can be doing as natural health providers to protect them and prevent these other things from happening down the road. Certainly stress, it's been documented in men in particular that stress worsens the sexual dysfunction. So how do we manage that stress? How do we turn down the cortisol? Are they doing exercise? Are they doing meditation? Any of those things that can help get them in a better, more calm space, better self-esteem, get rid of the performance anxiety, all those types of things need to be taken account for. Certainly the semen analysis we talked about, it can get pushed to the side, but it can be a really important piece of you helping evaluate your couple's fertility issues. And then we also know that men with oligozoospermia, so issues with sperm production, 42 to 50% of them also have hypoandrogenism, so they have low testosterone. And because testosterone is actually contraindicated as a treatment for those men because it actually suppresses testicular production of testosterone, and then they have even reduced spermatogenesis, we have to think about this outside the box and come up with other ways of treating their low testosterone. One way that I know is out there in the conventional literature, and I see more and more docs doing, likely because it's easier to manage than testosterone, is using Clomid in men, which may be one option pharmaceutically to help with testosterone and sperm production. But I usually turn, of course, to a more natural product like the maca Librium, the Revolution, which is our maca preparation to actually support testosterone levels, stress levels, and sperm production. Because maca can reach across the whole HPA-O axis, and in men HPA, we see that reduction in stress and help with the adrenal piece, but then we also see an improvement with the male hormones as well and sperm production. So we want to look at that totality and that whole picture. And I'll just do a side note here in particular about the feminescence and the maca products that we're talking about today. Is not all maca is created equally. There are many different colors or phenotypes of maca, and where one might improve testosterone and reduce the size of the prostate, another one might increase the size of the prostate. Another one is really great at managing menopausal symptoms, and the others aren't so great. So knowing what types of phenotypes and which types of maca you're giving your patient or in which formulation, that's the important piece. So people can have negative reactions to a maca powder that they got in a bulk section and they're throwing in their smoothie, but they may or may not, and they're likely not going to have those negative reactions to something in one of the formulations that we've put together. Because many of the ones that are in a maca powder are often about the adrenal support. So they can get the energy, they get the adrenal piece, but it may not be the right one for where they're at hormonally. So the Revolution is the phenotypes specifically for male hormones and supporting them. And then, of course, pH Quintessence is the alfalfa product that I mentioned earlier to help with gentle detox. Men are toxic as well. We're all overexposed to phytoestrogens and xenoestrogen in our environment. So on to women's health. we're going to look at some case studies, and I've already touched on a couple of these products. Specifically today, of course, is going to be the Feminescence Pro Harmony, because that's the one we're going to use for women in their fertility years to help enhance fertility, help with PMS and hormone regulation. Obviously, the Macapause and those others are for postmenopause and perimenopause, so they're not our topic for discussion today. I wanted to just highlight Herbatonin for just a moment. It's our plant-based melatonin product. There's a number of studies that are coming out on safety of melatonin in pregnancy and potential benefits for both fertility, ovulation, or not.
I'm wondering if her internet has cut out because
Easiest fertility. Am I still there?
There you are. I think we lost you for a second. Your sound.
Yeah.
There you go. Perfect.
Okay, good. So I'll back up just a little bit. Yeah. So 1 cap twice a day of the Feminescence Harmony typically is all we need to do. And I was just saying, it'll be on the recording, but I'll repeat it, that reminding our patients that a normal cycle is anywhere from 21 to 35 days. And so that may be that someone's ovulating early and not that classic 11 to 14 days, and using ovulation strips and finding out exactly when they should be having sex and timing that, timing intercourse is hugely important. And there may not be a fertility issue, it's just a timing issue. So just be aware of that piece. The other reason I really like using the Feminescence Pro Harmony is because I don't need to do a bunch of different protocols for follicular and luteal phases. It seems to enhance, because it's an adaptogen and a true adaptogen, we get balancing of both the follicular and luteal phases, and whether something needs to go up or down, the Feminescence is very good at doing that. So it's simplified my treatment plans tremendously into 1 or 2 products instead of having to use, you know, a laundry bag or a paper bag full of supplements. I don't use Vitex as much anymore. Some people just love seed cycling, and I'm all for it, but some patients find it completely overwhelming. But I don't necessarily have to do all of those pieces anymore, which is wonderful. And it makes it more cost effective, which is huge for people, especially right now with how many outside forces are affecting us. And very few side effects. Occasionally we find that someone's acne will flare up or something will shift for them, but it's usually just an educational moment in that it's working because we're shifting their hormones. But like we all know, oftentimes, and if you think homeopathically, there can be that aggravation before things get better. So if it's too much for them, they're getting some gastro side effects when they first take it, or they get a flare up of that acne, we'll just take them down to 1 a day for a couple of weeks, or maybe 1 cycle, and then go back up to 2 a day. If they're getting gastrointestinal side effects, I might have them take it with food for the first couple of weeks, let their body and their gut microbiome, everything get used to it, and then shift it to away from food. And so it's usually just simple alterations that we need to do with the dosing to really help people out. And we can get into some more of the dosing nuances later on. I want to make sure we get to the case studies. So we pulled from Dr. Stephanie Hayes, a colleague in Portland who works a lot with fertility as well. And she has another way of using the Pro Harmony, which I'm just starting to kind of play with after having learned it from her. But she has really been focusing on using it a lot for individuals with poor follicular growth and the luteal phase defect. And she's found a way that she's been dosing it where she's using it similar to Clomid or Letrozole, where she's doing 1 twice a day throughout the cycle, but then she'll increase to 2 caps twice a day in cycle days 3 through 7 to really help push that follicular growth. And she's having great results. So we're going to highlight a couple of those today. Where I usually go to 2 twice a day is more throughout the whole cycle with my PCOS patients or patients who have severe endometriosis. That's where I find going up from the standard dose of 1 twice a day to 2 twice a day can be necessary to really get balance on board and working and getting cycles regular. So I don't ever go higher than 2 twice a day, but know that some patients, you may have to do that. There's an element of explaining it's going to take a cycle or 2. I always remind people, hormones are a month-long cycle. So we should see improvements within the first cycle, but to get to our final destination may take a few months. So I like to set that stage and the reality that this is a process. And I try not to, as Stephanie points out here, that I try not to do a band-aid for that low progesterone. We really want to fix it at the root cause. And if we're addressing it from the HPAO axis, we're actually fixing the underlying problem versus sticking that band-aid of progesterone on that second half of the cycle. Not that I don't do that sometimes, it's necessary, but many times I don't have to go there with the use of the feminescence. So let's talk about a case study. This was a 32-year-old female referred by a colleague to Dr. Hayes for IUI. She had planned to go to Mexico to get IVF, but she wanted to try to use frozen sperm for 6 months first before doing that because her husband's vasectomy hadn't been reversed. So she had come in October, and it looked like a occult form of premature ovarian insufficiency with some diminished ovarian reserve. And really quickly, diminished ovarian reserve, just as a reminder, is going to be an AMH of less than 1 nanogram per mil. And that's a great measure because it's very consistent between cycles. Versus FSH or estradiol, they can fluctuate pretty widely between cycles. So in relationship to each other, they can be very helpful. But as a snapshot in time, it may or may not, you need to just use it with caution. Although it's a standard evaluation tool, we still just need to be aware of what its flaws are. So they can be very helpful in giving us clues around ovarian reserve. They're good predictors that someone will have a response to ovarian stimulation, but remind your patients that poor results do not predict the ability to achieve or have a live birth. And I feel that sometimes patients get very stuck on the numbers and they forget that the numbers are just numbers. They're what we have, they're a tool, but we need to think about the whole picture. So with that, let's jump in here. So Kelly, this gal, had previous labs from July before she came into Symphony in October. TSH, hemoglobin A1C, all these others, CBC, all looked fine. Her AFC, so her antral follicle count, was a little bit on the low side. Ideally, you'd have more than 6 follicles on day 2 to 3. Her estradiol is okay, not too high. We're looking for under 60 when the FSH is also normal. So ideally, FSH is going to be under 10. If FSH is normal, but estrogen is over 60, then we're also going to think about issues with creating follicles. And her AMH is less than 1. So that's where we'd like to see that above 1, and it's a little on the low side. She's taking a few other supplements. She had already come in on melatonin, CoQ10, fish oil, prenatal, myo-inositol, royal jelly, and some maca root just as a regular gel cap. 7 days post-ovulation, progesterone with what she was already on was 3.2, so not great. We'd like to see that at least at 8 or 9. Under 3 is technically the standard medical institution's marker for having ovulated. We have to be slightly aware of this as well, though, that progesterone can actually fluctuate 7-fold over a few hours. So it can be, we want to use it as a guide, but it's not a hard fact either because it has a very transient kind of nature. So all of these are guides to our thinking. Dr. Hayes switched her from her standard maca root formula to 1 cap twice a day of the FemPro Harmony, and then 2 caps twice a day for days 3 through 10. So pre-ovulatory. Progesterone retested a couple of months later, and it was at 17.4. So again, we know that there's some fluctuation in there, but clearly this is a much better level than where it was originally. She started IUI with the frozen sperm in November. She got pregnant after the 3rd one, but a blighted ovum. So that was a miscarry. Resumed, took a break, resumed a couple months later, and on her 5th one, so 2 more, and she got pregnant. So, and Dr. Hayes added a little bit of progesterone just to maintain that pregnancy through the 1st trimester, and healthy, happy baby resulted. So again, this goes to this is a process. And most of our patients who are dealing with fertility, they already know that this is going to be a process, but helping remind them throughout the process and keep them, again, we're really trying to focus on keeping stress levels low, not over focusing on the numbers. That's a big piece to keep everyone focused. Another case study, we have Caitlin, also Dr. Hayes's patient, referred to her for a known donor situation, and because her husband had azoospermia. Her first visit also was in October. 32 years old, so shouldn't have a whole lot of issues, young, still on the younger side. Previous that year, she had a normal thyroid function, D, ferritin, CBC, all normal. Her day 2-3 labs, she has a good antral follicle count. Her AMH is over 1 where we want it. FSH is okay and estradiol is okay. Good semen analysis of the donor. So things are all lined up, but it hadn't quite happened yet. She was taking her Rite Aid prenatal, so Dr. Hayes switched her to a higher quality prenatal with some extra methylfolate, added more vitamin D and a fish oil. And she had a 27 to 30-day cycle, which is great, but low cervical mucus. And her progesterone was not optimal. It wasn't frankly low and under 3, but it's not necessarily optimal either. So we want to really help support optimal ovulation and luteal phase so that we can get that IUI to take. So added the FemPro Harmony 1-2 a day for a month, and then added some melatonin at night. And the next cycle, she was pregnant. Progesterone, HCG, everything increased just as it should, and she gave birth to a healthy full-term son. So this is hopefully many of our patients who just need a little, came in with a number of supplements and CoQ10, Shatavari, myo-inositol, etc. Her labs looked okay. The ferritin was 10, so we need to get that optimized. Her FSH looked okay. Day 21, progesterone looks okay, but of course we have some motility issues with the sperm. Then the patient ended up with a foot injury, so she had to take several months off to recover. Noticed she had poor cervical mucus, and her cycle had been fluctuating a little bit between 32 and 23 days. So we needed to get that regulated, along with helping out with the IBS flare. Retested labs in 9 of 18, and AMH looks good. It's over 1, 2.43. Her estradiol is okay. It's a little on the high side, but it's not at 60. FSH is 7.6, and her progesterone was 11.6. So not optimal, but certainly not terrible labs. After some treatment, her ferritin got up to with the iron, her ferritin got up to a better level. Her other levels all look good, CMP, CBC, etc. Her ND had moved away, so Dr. Hayes had the opportunity to kind of simplify that long list of supplements that she had been on, and she ended up doing just fish oil, D, iron, a prenatal, and the FemPro Harmony at 1 cap twice a day, with that increase of 2 twice a day for days 3 through 7, that the patient could regulate whether or not she was having good cervical mucus, and she could lower or increase the dose as needed. With that, she ended up getting pregnant 6 weeks into the new protocol, added a little bit of progesterone just to help maintain things, but everything continued to be viable and move forward. Beta HCG was great at 29,000 after 7 weeks. And then her progesterone had been just a little low still, so increased that progesterone until for the full first trimester. And then last Dr. Hayes saw her, she was 30 weeks pregnant and everything was going great. One note I'll make here about that first trimester is oftentimes when we're using the Maca Harmony to help people with fertility and ovulate and get pregnant, we'll leave it alone and continue it through the first trimester, often at a half dose. So if they're taking 1 twice a day, I'll reduce them because of course we don't have long-term safety studies and everything. We presume the maca should be safe in pregnancy, but we'll often just reduce it, but keep it on board to help promote that progesterone and help support the hormonal balance until that pregnancy has taken hold of itself after the first trimester. So 1 cap a day through the first trimester is typically what I do, and then they stop at week 13. A couple of quick notes, that wrapped up the cases. A couple of notes on breastfeeding. Of course, you can't really study this, but typically we don't recommend using the Maca Harmony in breastfeeding because theoretically you don't really want balanced hormones when you're having breastfeeding and lactation because the body is trying to keep things low, often not even cycling with a period so that you can support more milk production. So I will use it with some gals, especially with postpartum depression, but I want to make sure that milk supply is nice and strong. They're doing well. They're not, baby is latched, everything looks good. And then I might start at a very low dose, maybe even just 1 cap a day, see if that helps lift the mood, any hormonal headaches, anything that might be going on for them, maybe going up to 1 twice a day. But I do definitely weigh the pros and cons, and I monitor their breast milk production, all of that, to make sure that we're continuing with no issues on that front. With that, actually, we can go to questions. And I know, unfortunately, I dropped out a couple times. So if I need to go back and review things and flip back through the slides, I'm absolutely happy to do that as needed. So Kaylee, how are we doing?
Yeah, so we did definitely a couple little like video and sound kind of skipping. Definitely better now. So I think maybe around the case study, the third one there was probably a bigger drop off. But
Okay.
if there's anything that people want to go over, I think the first drop off was around the men's hormonal. I was gonna just see if someone had said something about a little bit of a drop off around like a men's slide, but we do have a couple other questions, so we can go through those too. And then if you have more slides that people want to go over, just put in the questions. We do have some needs to go over some of the first slides, so I'm not sure if there's any specific ones, maybe type them in there, but we can go through some other questions first. So one of
Great.
the, I'm going to apologize in advance for any of my pronunciation on these questions coming through. So one of the first ones are, I think it's closer to the beginning, are there product detail sheets from the Feminescence products, including the Maca Librium? And
Yes, there are. Oh, sorry. Go ahead and finish the question.
oh no, and then it's just like, what is the name of the company that makes these products? Is kind of a combined
Great.
question.
So Symphony Natural Health is the maker of the products. The Feminescence line, there's 3 products that are specifically for women. So there's the one we talked about the most today, the Feminescence Pro Harmony, which is for younger women and women who need help with fertility. So it's not just for fertility, but any gals who are having PCOS issues, irregular cycles, terrible PMS, PMDD. That's the formula we would use with all of those younger women. And then there's the Feminescence Pro Perimenopause, which is for the perimenopausal woman, obviously, who's having fluctuating cycles and the hot flashes and all of those things. And then the postmenopausal formula. So women who have fully dropped off, no cycles for a year, the postmenopause is going to be the most supportive at helping bring those levels up a bit. And then there's the men's product, which is the Revolution Maca Librium, which is the maca specifically for managing testosterone and helping support more the adrenal aspect and the testosterone aspect.
Okay, great. And I have a question here. It says, it is not clear from references how safe the maca is to use if patients take it through the first trimester, as they may not know if they're pregnant at first. What do you advise?
I think I ended up touching on that at the end. As with most things, and we all know patients who are like, oh my God, I went to Vegas and I didn't know I was already pregnant. Generally speaking, you're not sharing a blood supply right at the beginning. A lot of people don't know they're pregnant through the first trimester and they are still drinking or smoking or doing whatever. Obviously, none of that is advised and we'd like not to. But maca is safe from a perspective of we don't see any adverse effects, and the toxicology studies we've done have taken mega doses in mice studies to cause any problems. So we do presume it's safe. We know it's supporting hormones, and what I found clinically is I haven't run into any issues with it. I reduce the dose to be safe, but I reduce it and maintain it through the first trimester, just like someone might add, and Dr. Hayes's, the case studies we looked at, added progesterone. I think about it as a support for the whole system until the placenta and everything takes over and we know that everything is established. And so I personally don't have a lot of issue with it, especially when we reduce the dose. And if we have any other safety studies or anything like that, I think Lisa and Melanie, our reps, can help get that those references out to folks.
Yeah, actually, well, there is a question on the men's product, I guess. Can women take the men's maca preparation if they need to increase testosterone?
We don't typically recommend it because when we're using the female forms of the maca, it again is addressing the whole HPA-O axis. So we often see improvements across the whole spectrum. That said, I recently talked to a practitioner who is using the maca Librium in women and in herself, and she only takes like once every third or fourth day, I think, and she swears that it's helping improve her mood and libido and everything else. So I would say it's not a typical recommendation that we make, but I won't say that I haven't heard of it being done.
Ah, okay. How much does a woman being overweight, possibly obese even, affect trying to ovulate or conceive, I guess?
I mean, it can have a huge impact, especially, I mean, certainly with just insulin resistance. And that's kind of, I think about it kind of like PCOS, where we have insulin resistance metabolic syndrome. The body is not happy. There's oftentimes some subacute or chronic inflammation that's happening. And it's just not necessarily the most fertile environment for the, or least stress-free environment for the fertility and ovulation. That said, we also know that there's any number of women who are overweight, but they are perfectly healthy. And so it's not necessarily an issue. And for other women, it will be an issue, in which case I think about approaching it a little bit like PCOS in that we're going to try to support ovulation and the female hormones and regular cycles, but I'm also going to be thinking about the insulin resistance piece. So whether that's some myo-inositol or it's some saw palmetto, checking their androgen state, whether or not they have too much testosterone or anything around. So, and then of course supporting good diet, exercise, all of those other pieces, and it may be a little turmeric if there's some inflammation. So that's how I kind of think about addressing it a little more as that whole person, and how can we support not just the hormones, but all the other metabolic endocrine systems additionally.
Okay, so I think these are a couple kind of around that case one, case study one. Are these hormonal tests being tested through blood or saliva, and which do you prefer and why?
These were all done through blood, and likely, if Dr. Hayes is on the same thinking as I am, it's often because that's what the standard medical community recognizes, and when we're monitoring fertility, that's the standard, so that's what we're doing. And so these were all serum, and because we know from the research what levels we're aiming for. I will use saliva occasionally for people, especially like where we're just not getting anywhere and we're trying to figure out how are you breaking this down, what might be going on here that we're not picking up. But typically in fertility, I'm using the standard testing through serum that the rest of the medical world kind of recognizes. And that's also, especially when you're having to do it serially, being able to utilize insurance is important, or for most people, and the serum tests we can all get covered.
That's good to know, yeah. And so why vaginal progesterone rather than oral? Progesterone, is that right?
Yeah. I don't use as much of the vaginal, or I don't use as much of the progesterone. I usually get away with just using the Maca Harmony. I know in the fertility world and with Dr. Hayes, the vaginal, because it is acting more locally and you end up getting to give less because you don't have first pass through the liver, that's usually the thinking around doing vaginal versus the oral. But I know both can be used.
Okay. Great. So those are kind of our main questions here. There was a few that came in. There was a lot of comments on, great presentation. And then even though we lost a little bit of sound, it's still very, very engaged, and people are definitely thankful for that you're here. We will package obviously it up and make sure our Fullscript video team can try to work some magic on there, and maybe include some resources and websites for Symphony Natural Health and Dr. Mona to share in the follow-up emails. So keep an eye out for that for sure. If there's any other questions too, we can stick around for a bit and see. I know that that the case studies, one case study kind of we lost a little bit of sound, but there was a lot of comments about how it was great to see, you know, those and the details and the steps that went through the processes. So if any resources we can send, we can definitely include them. As I said before too, our webinars live on Fullscript's webinar page, I guess, fullscript.com/webinars, and we can include those for sure up there, and it'll always be there, so you can go back anytime and check that out. Is there anything else you wanted to add, Dr. Mona?
No, but I might open it up if Lisa or Melanie from Symphony have anything else they'd like to add. We can certainly let them jump on.
Yes, we have some more guests in the background.
Hi, thank you so much for joining us today, and thanks, Mona, that was great. We are happy to send out any literature or any other materials that you requested. I'm sure that Kalia can put our contact information out to you after the webinar. And if you have any other questions, we are certainly available to answer those. We also do a weekly product training that you're welcome to sign up for, and we can put the product training link as well into the response, into the follow-up. So if you have any other questions that you didn't get answered today, we can answer those in the product training.
Yeah, I'm just going to make a note to make sure I include that in there. But no, I think these resources along with those will be amazing with the recording. We should have a great bundle for the attendees, and if they just registered as well, there's access to it for everyone. So I guess that.
Can I address one other question on the topic of Mona kind of addressed it around revolution for testosterone, and that's kind of a really specific case that she's talking about. We typically don't recommend alternating the formulas, but we can get back to you on that with a more broad answer if you want to give us your email, and we can do a follow-up on that question. So there are people who are doing it that way, but we typically don't recommend dosing it that way for a myriad of reasons. And so as she said, using feminescence as first line, therapy, and then kind of filling in after that is something we'd like to discuss more broadly with you before you alternate the formula.
Yeah, and if everyone is wondering where they can kind of make it easy to ask questions too, if you want to email webinars@fullscript.com, I'm happy to forward on questions or include them in the resources as well. We did actually have one question come in. Are the products available in Canada as well as the US, or one over the other, or?
We are in regulatory with Canada right now. It's an incredibly arduous process. And so we hope to be soon. We do have Canadian practitioners who order from us directly, and we ship to Canada, and it has all of the shipping costs associated with having to ship into Canada, but otherwise we do ship there, but we're not through regulatory with Health Canada.
Yeah, tricky to get up here, eh?
It is.
Okay, well, as I said again, webinars@fullscript.com. We will post we'll post the webinar recording and all resources we can on our website, but you'll get an email directly to your inbox if you've attended or if you registered. So I guess with that, I'd just like to say thank you, Lisa, for joining us. Thank you, Dr. Mona, again for a great presentation, and for everyone joining us today. And we hope that you guys all have a great day and stay safe and healthy.
Thank you for having us.